we'll just dig into it.
All
Where you
right.
from? How long you've been here, and how did you get here, by the way?
To Columbus?
No, yeah, to America.
Oh, to America.
Were you born here?
And no, I actually wasn't.
Okay,
I was
okay.
born in Somalia. I came here 2000. I moved from Somalia after I was born there to Pakistan and lived there for a while. Then I came here about when I was like 7-ish.
What do you remember about living in Pakistan?
A lot. That was a lot of
Okay.
where my memories come from because I was only like 3 when I left Somalia.
Okay.
So it was very interesting. That's when I learned Somali and Urdu and English all at once.
All at once.
So,
Excellent. So
at once.
Okay. I feel like, people that speak multiple languages are more smarter than people that just speak only one language.
I do believe that just because your brain just has to switch between certain things. And I think it's very fascinating, actually.
Okay.
I wish I could learn more languages. Like I always tell people I wish I was Rosetta Stone so I could just have all the knowledges of the different cultures, the different languages. It's a beautiful thing.
Your early childhood, right, in Pakistan. What do you remember the most?
I'm trying to think now.
I guess what I'm trying to get at is, what's it like living there?
Honestly, it felt, especially at the time,
Okay.
Early 90s, felt very, very freeing. Like I could walk, by myself at 5 years old to the market, come back, felt pretty safe always. I just felt like I had a lot more, autonomy over there.
Gotcha.
Eid felt a lot more like Eid.
Okay.
That's probably able to celebrate Eid and, just being in that country where it feels that way. So
Gotcha. So you left there when you were 7 years old?
yes,
Okay.
I think I was, almost 8. So yeah, I think I was 7. So.
Okay. So you came here to America. What is that transition like? The experience and culture shock. Yeah, I bet.
Honestly, first things first was, one, people assuming I didn't speak English, but in every part of the world they teach English. So one of the funniest stories I tell people is that I spoke over there. They teach a lot of British-based English.
Okay.
So when I was, I think, in like the 2nd grade, we would always have spelling tests, and every single week I would constantly spell the word color wrong. And then my teacher sat me down and she was like, "Why do you keep spelling it this way?"
Yeah.
And I'm like, "This is how it's spelled." Like,
Yeah.
I'm not, but just with the U and everything like that. So just adjusting to that. I will say one of the biggest things I recognized early on was the level of education was very different.
How so?
I was in 2nd grade, but I was able to do the math that they were doing in 5th, 6th grade.
Here in the United States?
Here in the United States. So I definitely felt the education system was a lot different
Gotcha.
than what I was used to.
They were too far apart.
Way too far apart. But I think because of the way like things were structured here and how my birthday was in the fall, just like starting school at a different age.
What is this starting? Let's just say, here it's early fall all the way to like late spring. So how's the structure there? When did they start? When did they finish? In a regular school year?
I think it was about the same from what I can remember.
Okay.
It was just more so of the structure of schooling. So over there we had, in the morning we would have the whole school would be out in the yard. We would have a lot of, we would practice karate. So every class had their own level they were at, but the whole school would do like karate or some type of yoga in the morning.
A lot more like physical activity.
A lot more physical activity, just starting off the day.
Okay.
And getting that energy going. And then we would, go to class. It was just a lot more structured in that way. Whereas here, I felt like it was a lot of, it didn't feel as cohesive at the time to me.
Gotcha.
So I think that was definitely the first thing that I
don't know, and when you came here, people didn't think you speak English. So
they think I spoke English, which was very interesting because I also was quiet in the sense of I was shyer, so I didn't speak a lot. So they just thought I didn't speaking. So it was very interesting to see.
Okay, so what inspired you to go to a pharmacist?
Honestly, I didn't even know about pharmacy.
Okay.
And I think that was one of the biggest things is our traditional become a doctor, become a nurse.
The immigrant way.
The immigrant way. But I learned about it, I think high school. And I was always interested in the health field. So I always knew I was going to go in that direction. But once I learned about, like, the more I learned about pharmacy, I had started doing some shadowing at pharmacists at the hospital back home. And I just found it very interesting, just very intriguing about how things work, how medicine works, like, how do you know what to do in the body? So I think that's what really drew me to it. And I also just recognized it just wasn't a field that was common to, especially our population, and our demographics. So just made me more interested.
Okay. Right now you work for Nationwide Children's Hospital. You also work at the High State University. So in between those two places, what is the common thing when you are in pharmacist that you don't see that a regular doctor do?
I think the biggest thing is it depends also what side of pharmacy you're on. So if you're on the inpatient side versus the outpatient side. So the inpatient side would be considered more so when patients are admitted. So you are more so in communication with the nurses, the providers, and so forth, and not so much more the direct patient conversation. Whereas on the outpatient side, you are the first line of communication with the patient. So you know things prior to even the providers would know. So I think that's definitely the thing I would say is there's been so many times that we've been able to help correct and manage patients' care because they have divulged information to us in our meetings that they haven't, the doctor doesn't have that knowledge of. Because when they're in a visit, they have that a lot of time. They're, discussing this. So a lot of those things I think would say we're first line to see. So.
What's your day-to-day look like in between the two places?
In the two places, I'll start at Children's.
Okay.
Children's, it's an outpatient ambulatory, in which what we would do is we take care of our pediatric patients in all of our outpatient clinics, as well as our patients that are discharging. So we have different services based on what their needs are. But my day-to-day would be communicating with providers, communicating with their patient's care team, patients, and just managing that care and being essentially kind of a liaison between that, and also being, providing recommendations to providers because we are the medication specialists. So they would come to us. So just it encompasses a lot.
Okay.
So.
What do you like the most?
What do I like to look? They get so excited about the smallest things. They're just a bundle of joy. So I definitely enjoy that. And I think one of the most rewarding things is just seeing the impact that we, specifically for me and being, the small and speaking pharmacist, just being able to connect with those patients, and when they first see me, they, might not divulge as much information, and then seeing a familiar face and being like, oh, howdy. And then just being like, and then just asking so much more questions that they would, necessarily
would not ask like if there was somebody else.
Before.
Absolutely.
So, just being, impactful in that way is definitely so rewarding.
So you see a lot of immigrants.
I do.
You see a lot of Somalis, a lot of Napoleons, a lot of...
We see everybody. We see, we serve such a wide patient population and demographics that I think you kind of see everybody. We have so many services also for, and I think that's the one thing I do enjoy, like where I work, is because we do have a lot of services and a lot of resources and a lot of support for those patients.
Are you the only Somali that pharmacist there?
Yes.
Okay.
As of now, yes.
Okay.
We do have ones in training.
Yeah.
So.
Oh, okay. Excellent. Because I think the number of professions in any area here in Columbus Ohio specifically needs to kind of sort of reflect. This is my own opinion. Needs to kind of sort of reflect the population that live here.
I 100% agree.
Do you understand? So that goes for policing. That goes for pharmacists, the doctors. These are people, not individual business owners per se, that actually in the work field that actually doing.
No, I think we definitely need that representation, especially, I say my personal opinion, I say like in Minnesota, like because they just have such a big population of Somalis, they do have a lot of representation in a lot of different, places and a lot of different professions. And I do think that is something that we can, do here as well
I
and
agree.
encourage that.
I think the mentality between the two states is a little bit different.
It's very different.
Very different, very different. And I think that's what drives that one community to be more thriving than the other. Not to say that Columbus is not thriving, but yet at the same
I
time,
agree,
I think you know what I mean. So I think
I think that definitely plays a big part in
exactly,
it.
Exactly. You can see the parents' face lit up when they see like how can I help you? You understand?
Hey, sometimes they just ask for me. They're like, oh, that's who I. And even if I'm not working, they're like, hey, so and so is looking for you.
Excellent. Because I feel like knowing the culture just kind of sort of eases a lot of doubts, a lot of
it does.
you know what I mean. So especially dealing with kids and you're a parent, you want to be able to talk to somebody who can guide you and at the same time know your culture and your background, all that stuff.
And I think too that it comes into like just one, it's health literacy, and two, it's also distrust a little bit in the medical field for our like patient population and our demographic. So just being able to have somebody in that representation definitely eases a lot of that anxiety.
Yes. I'm more interested in finding a little bit more of, do you see a more common cause? Yeah, you see what I mean? Like, do you see a more common cause for our people that are coming through the pipeline of nationwide? One common, like for example, like, majority of them do come. I guess what I'm trying to figure out is like, do you see like a similar medication similar medication getting prescribed for the same population or the same culture? Does that make sense?
Okay. I do understand what you're asking. Okay. Just paraphrasing in the sense of, is there a commonality in either disease states or medication management for one like our patient population?
Yeah.
Honestly, I wouldn't say a commonality in the sense of like there's just so many varying needs that we have, but I do think one that I do see, and not just specifically with our patient population or our demographic, is H. pylori.
What's what?
H. pylori.
Okay, what's that?
It's pretty much a bacterial like intestinal infection.
Okay.
And bacteria.
And these are for kids.
It happens to a lot of people, but I see it a lot more in our immigrant population.
Gotcha.
And a lot of the times it's it's the symptoms are, appetite, like they're not having as much appetite, so appetite reduction, not being able to like hold food down, a lot of those things. It just seems like general symptoms. Okay. And you wouldn't really necessarily know until they test for that.
Okay.
And that's not something like right off the bat commonly that they will test for.
Okay.
And it's something that it just takes, an antibiotic course. It's like a course of antibiotics, a course of, acid suppression, like kind of the heartburn for a few weeks, and to eradicate that bacteria. But that is something I see commonly in immigrant populations.
Population. That's interesting. Yeah. So what can they do to prevent it?
It's not anything preventable, because I honestly don't know why it's more prevalent in our immigrant population. Okay. I'm not sure if it's based on, where we come from, based on, dietary. I'm not necessarily sure.
It's a little bit of both, especially where we came from.
Yeah,
because there's a lot of more things that we're exposed to comparing to, here it's more kind of sort of a controlled there.
But I don't think there's anything necessarily prevention, but I do think it's something that I do tell people about. It's common knowledge, I would say, for them to know that. So, and a lot of the times it gets misdiagnosed in the sense of like, it could just be, a stomach virus or a stomach bug, or, just in that type of sense. And it's not something that just goes away. It does need to be treated and eradicated. So, how
often do you see a misdiagnosis or somebody getting the wrong medication because simply that they weren't able to express their feelings, express their needs, even if they know the need to begin with?
I wouldn't say in the sense of misdiagnosis, but I would say I've seen a lot where they are trying to communicate what the symptoms are and what the things are, but not necessarily able to communicate that. And I would say the thing that we have, especially at like children's, I could say, is we do have a lot of language services. So that barrier, thankfully, is like reduced a lot. So I don't see it as often in that sense, just more so in their understanding of what they're taking.
Yeah.
And that's a lot of why I think I connect a lot with our patients, our Somali speaking patients, just because I'm able to explain to them the whys of things. Like here, they're like, oh, and I just letting them know the importance of like having at least like, especially for those kids that are complex needs, just having a list of this medication, this is for this. And a lot of the patients who have been on their treatment for a long time, they kind of have picked up on that.
Yeah.
But that's something that I think is very important, is knowing what the indication for things. Why are you taking this specific medication? Because a lot of that could start conversation. I've had those conversations of like, hey, why are you on this medication? Has everyone, they're like, oh, I've just been like, followed up from a different provider, or, and I do think that we have a comprehensive team at Children's that is able to kind of filter those things out. But just overall in general, I even, with my mom, with my, how I did it update, I always give that type of information, because I'm like, hey, I want you, like, and I think one thing that we do, especially as pharmacists, we try to get that patient to take ownership of their care.
Yeah.
And to be able to understand, like, to have control of that, of their care, so in their management, to be a part of the team that is treating them, because essentially it's them, and their child.
Yeah.
So.
Have you had that conversation with an adult, meaning that some people are just from a medication that has been described for them for a long time, and they made it just a regular, and just that's their part of the lifestyle. This is a blood pressure, it's more so mentally than it is that actually the sickness itself. And so they continue to take that medication until a point of no return.
I don't necessarily see that in my personal experience. However, I do see, since you brought up blood pressure, which I'm going to veer a little bit to answer that question, is I do see a lot of times where we have had more so our adult patients in those clinics that they are just have complete uncontrolled blood pressure or hypertension, and it's for them, they still call blood pressure the silent killer.
That's right.
And our demographic is has such a high prevalence of blood pressure, or hypertension or high blood pressure. And I think I've seen it a lot where they just don't understand necessarily long-term medications. In the sense of like, right now you have a headache, you feel the pain, you take ibuprofen, you're good. Whereas there's not really symptoms that it's over time. And I think that's one of the biggest things I try to emphasize is like, it can cause strokes, it can cause a lot of cardiac or like heart issues. So the importance of taking it, I see the opposite a lot of the times, where you said where people are on medication, they just take it forever and ever and ever. I generally see the opposite, where they're not taking the medication, and it is a long-term medication. And a lot of it is, like I said, related to the health literacy or understanding their disease management and why some things are more long-term in their care versus like more acute or short-term in their care. So I see the opposite actually, where people are not adherent to their management. For those disease states, diabetes is a big one. But I think high blood pressure and diabetes is probably the biggest ones that I think that our population doesn't really adhere to or doesn't fully grasp the necessity of long-term care.
Are there more educational that's offered to people like that, or maybe just a wide range of people that today we have a class that talks about diabetes, and you're more than welcome to come and kind of sort of understand that somebody that can speak your language.
I don't necessarily know is specific, and that's a good point. Maybe something I should look into is like necessarily having those language services available in those discussions. But because we do have those resources for patients, we do have those resources for parents, but I think a lot of it also is on the onus of the onus is on the parents or the patients to grab that or to reach out for those resources.
I mean, it is challenging for in
the buy-in is challenging.
It is. Big time. So whether that like they feel like the necessity to hide their sickness, or they don't feel comfortable coming out of it, but at the end of the day, it's just that's a silent killer. You slowly chipping it away before so and so didn't wake up from it's just it's a
seen those too. So.
And I wish this is where the comparison Minnesota comes into play. There is a lot more more of educational,
Community-based.
community-based. Thank you very much. Community-based. Here is more so like individuals that are just running on their own way, but more so it's collective over there, where the information is just kind of sort of transferred that,
And I think that's the biggest thing that I've also noticed is more of a collective approach and more of a community approach in the sense versus individual. And, I do think, not veering specifically onto pharmacy, but just in general for, especially our youth.
Like mental health.
Yes, that's where I was reading to.
Mental health.
Mental health is a huge component of what I see. And even in, I have seen
more in a nationwide or more in OCU?
Generally across.
Okay.
I just mean in general, like our demographic.
Yeah.
But, I do see a lot of, patients too who are, Somali patients who are, have a lot of behavioral health needs, a lot of mental health needs. And just that understanding is so hard, I think that even in any population, not just Somali, American, it's very, and I think now it's becoming more open to talk about and more open to get that help.
Yeah.
But, try to telling somebody, hey, you have PTSD. And it's just talking about, oh yeah, I came from, war. I was waking up to, and why wouldn't you have trauma from that? Why wouldn't you?
Yeah.
And it's not even necessarily medication based. It's counseling services. It's, just seeking those opportunities. But a lot of it is, rooted in the ebb.
Yeah, it does.
In keeping those things hush hush of like, oh, like, no, I'm okay, I'm good, and just suffering silently, you know?
Yeah.
And I think that's definitely a conversation that community-wise we, can do better in starting those conversations and engaging our youth in that especially.
Yeah, and I think that's one area that we lack.
We lack a lot. And unfortunately, I've seen from personal experience, from just an overview, lives being lost to that.
Yeah.
Young lives being lost to that. And it's very sad and it's heartbreaking.
Yeah.
And, whether it be the mental health that leads to the substance abuse or the substance abuse leads to the mental health, just it all intertwines, you know what I mean?
Intersect.
Yeah, it intersects. So.
Absolutely. If the mental health is not driving into substance is driving into mental health. So somehow they intersect and they meet, and it's all that is just swept under the carpet. Like you said, it's now, for some people or some generation, it's okay to talk, kind of sort of bring it to the surface a little bit, but yet I think we still have a long way to go in a sense of that, addressing it, and halfway of solving that problem is acknowledging.
Oh, that's step number one.
Yeah.
Like step number one is saying, hey, this is a problem.
Yeah, this is a problem. So when you acknowledge that, you should feel some sort of like relief on that aspect of like, okay, hey.
I think that's where it comes in the ebb of like,
I know.
And
the shame of it. And if you link that with it, and it's just, do I rather be felt ashamed to treat it as such? Or, like I said, there's young professionals like you, hopefully, that will bring to a light to many people, and hopefully, that may change the mindset of the upcoming. Because I think we're getting to the generation where the young professionals should speak up. Yeah, I truly believe, because some people are never going to change that consider the leader of the communities and ways. I think they'll always be, and that's not to their fault, because they only know
what they know. Yeah,
they only know what they know. Have you ever heard the term that if you have a hammer, you think everything's a nail, right? So, and I think that is
the same similar concept.
That's the same concept. It's showing there, and they don't. How you tell in generation it's a flourishing, how they develop the youth. If the youth is developing themselves, that will say a lot of things, right?
Hey, but
hopefully the next generation in that.
But no, what I was going to mention earlier is I think one of the biggest misconceptions is one that is an individual problem, know, and it's not. It's a systemic problem. There's a lot of buy-in, from, what resources we have for the youth, to have spaces for them, to have organizations or just things for them to feel like they belong in a certain place. and that they don't have to go, to certain things to feel belonging or feel like, that feel that need essentially.
Yeah.
And then just is minimizing their experiences. A lot of times it's like, oh, we're older, we know what's best, we know what's this. And sometimes I just think it's just listening to what their experiences are, because yes, they may be younger, but they have a different experience than when we were younger.
Yeah.
And just allowing them to have that autonomy and to have that experience to be able to speak about those things, I think, and then taking that information in and then guiding them versus just, nobody wants to be told you're wrong all the time.
Absolutely not. Absolutely not. That's almost like, damaging.
Exactly.
Yeah.
And it's not going to draw people in. It's going to draw them further away from you.
Oh, absolutely. Absolutely. Yeah.
So I think that's one of the biggest things is understanding and honoring their experiences.
Yeah.
And the world that they live in now.
Yeah.
It's different than the world we lived in, and the world our parents lived in, and so on and so forth.
Oh, yeah, absolutely.
So I think it's just acknowledging and honoring that.
Yeah.
I think that builds a level of trust, and it builds a level of, connection for them to be able to feel like, hey, I'm being heard, and and it's not, I'm not saying it's easy by any means, but I do think that's a great place to start.
Yeah, I agree with you. You mentioned two important things. You said space for them to kind of sort of express, and resource. I think the resource is available in I don't mean on a parent level, but I mean like in which the country, in general speaking, the country which we live in at the moment, right, in the United States. But I think we need to come up with the space. I think we need to.
I think that's the biggest part. Yeah.
Yeah.
I agree. And
for them just to express, hey, I went through this, but if you don't allow them to come and say, hey, this is what I've been through, maybe it's not the right thing, but this is my experience and I'm willing to change, or maybe guide me without you judging it. I think that's comes down
and
to
I will say, to correct myself, not just space but safe space. That's the key.
Yeah, absolutely. Absolutely.
That's the key.
You're
It's them feeling like they're not going to be reprimanded for expressing what they their experiences are, their thoughts are, or their feelings around a certain topic that might be taboo, and I think that does a lot, like, more for them. And for that, I think a big part of it is building that trust.
Yeah.
And that's where I believe that we can start.
Yeah, it comes down to trust, like you say, safe space, resource, and acknowledgement of the situation in which we are.
I mean, like you said, I can give you all the resources,
right,
but if I don't have the
exactly. So in your line of work, do you see people abusing like a certain medication that kind of sort of it's almost like substance abuse type of thing?
I would say more so in like where I work at OSU with the adult population, just from my personal experience.
Right.
From children's perspective, I think that we have such a variety of clinics for different types of substance misuses or substance addictions and things like that. So I do see it, and I do see the detriment that it causes.
Yeah.
Where it's either they started misusing it because they got it from a friend, or this is however they obtained it, and then that just became the need at that point.
Yeah.
Again, that goes back to the taboo of the shame of it all.
Right.
And till it gets to a point where you can't ignore it anymore.
Yeah.
It's either you're harming yourself or you're harming others to that point.
Yeah.
So I do see it from that aspect of those patients who are in there to get those treatments, more so than necessarily.
What is the interaction like once they realize you're from
well, from Somalia?
Yeah.
Interestingly enough, I wouldn't say more so for the substance misuse aspect of it, more so from, I think that's one of the biggest ones where I because most times, like I said, they're very happy to see me.
Yeah,
they're very
yeah,
oh, hey, somebody I can talk to, somebody who can understand me.
Yeah.
Whereas with that specific aspect, there's that resistance.
Yeah.
Of you guys know, you know what I mean? They're gonna know and I think this is the first thing I think that people should recognize. There's a professional line there,
Yeah.
You're a patient, regardless of whatever this
and you're protected. Yeah.
You're protected.
Yeah.
You're protected by HIPAA.
Yeah,
You're
absolutely.
protected. I quite literally can lose my license and my job
Yeah.
for infringing on that.
Yeah.
You know?
Yeah.
And I think that's the biggest thing, where is they don't understand how strictly I would have to adhere to the,
Yeah.
to the professional standards.
Yeah.
You know, where there's no judgment there.
But in their mind, they're the cultural thing.
The cultural
the
thing
that
comes
they have been
up.
exposed to. Yeah.
And I've had patients who requested that I not be in the room.
Yeah, and the other thing is that,
Yeah,
which
yeah,
is
just,
fine,
you know?
no problem with that. I totally get that, because it's we are a nation where we like to call ourselves like we're oral society. You know, like we don't write stuff.
Yeah.
We don't write shit.
Truly, it's word of mouth.
Yeah. So it's really word of mouth, and it's just ridiculous. I mean, now people are writing stuff and their experiences. We get to see a lot more book publishing or book signing events, like from Somalis that are sharing their experiences. You know, I have one in my mind too that I want to share my experiences as well. But at the same time, it's like, you know, if you look deeper history, you got to see, I mean, not the only thing, but the majority you will see, like, foreigner writing about Somali, not Somalis writing about things.
Not us owning our own story and writing. Yeah.
But there are like poetry people that really,
You know, the land of poets.
yeah, with the line of poets, you know, but and they're writing now. But you know, how often can you or say Wallahi people will understand that poetry to be? Do you get what I'm saying?
Translated,
So
yeah.
translate exactly. So there's a lot of work to be done. But yeah, when you can see that creeping in to somebody that who really need help, just simply to avoid that, you know, the same.
And you know, I think
Country.
the biggest thing is at the end of the day, patient care is the most important thing.
Yeah.
So
yeah.
whether you want me, whether you don't want me, as long as you take it, that's what's important to me.
Yeah,
You know what I
yeah,
mean? And I'm gonna honor that.
Yeah.
And I'm gonna this had kind of things I had to explain to a couple people where I was like, hey, it's from a cultural aspect.
Yeah.
It's not a personal thing.
Yeah.
You know what I mean?
Yeah.
It's just from a cultural aspect, and I understand it.
Yeah.
And I'm gonna honor it, you
Yeah,
know?
yeah.
But I do want to like acknowledge that issue and that problem of you know, like that shame and things that shouldn't come with shame.
Yeah.
You know what I mean?
Yeah.
At the end of the day, like Ilahi is the only person we're not the person, but the only entity that we're answering to, you know?
Yeah. It's God. Allah.
It's God. So I think one of the biggest things is removing that shame factor with things.
Yeah.
It's removing the blame of it being on an individual.
Yeah.
You know? Wherever life leads you is where life leads you.
Yeah.
And only Ilahi knows best. You know what I mean?
Yeah.
And so I think that's something that I've really seen a lot in, like I said, a lot in that specific aspect.
Yeah.
It's
The shame is way deeper than that.
way deeper.
Yeah.
Way deeper.
Yeah.
And
I don't know how much you can talk about that, but I think the shame is way deeper than that.
it's very deep, and a lot
it's
of
like from the religious aspect of it. When you, I mean, that's the most that holds into that. You know, I'll share a story with you. I heard this when I was visiting London, but it happened in somewhere in Denmark. One relative was just kind of sort of that childhood classmate who was just talking about something that they experienced. That, you know, when you go through a civil war, there's so much of side effect, like is one of it, but there's more deeper side effect that a lot of people really don't talk about, and you know,
bury it deep.
Yeah,
that it just shows up.
It shows up at a great time.
Yeah.
So this person got married to somebody that had that virus, HIV. They didn't tell them, and they were explaining that this was a vitamin. After I think there was like 2-3 kids, and that person happened to be in somewhere in Europe, got accepted as a refugee, and as they were going through the process, you know, they were told that this is what you have, and she couldn't believe it. And you know, I'm only been with one person, so how would that happen? And those are the father of my children, and how would that happen? And he used to take a vitamin daily, and I think, you know, it's like an onion, you peel the layers one by one to get to the point. So, and finally had to confess on that, and so the feelings that person will go through, and the challenge that person will go through, and the shame that person will go through.
There's depression in it. There's a lot deeper things that are just bigger. Bigger than the disease itself.
Yeah.
And I think one of the biggest thing is, you know, alhamdulillah, we've come so far and like advanced so much in our treatment, specifically for
I think almost right now it's not it's not as bad as it was.
No, and I think that's the biggest thing that people have to understand.
Yeah.
You know what they say, U equals U, which is undetectable equals untransmittable. And there's people who live long, happy, and healthy lives
Yeah.
with their treatments.
Yeah.
And have kids who, don't have,
Yeah.
that's not transmitted to them.
Yeah.
So I think it's just that misconception
Yeah.
and the fear of
Yeah.
and more so than understanding
Yeah.
and coming to hey, this is a disease, and a lot of it too is sometimes in that situation the patient or the child could be born with it,
Yeah.
and they have just contracted it from birth.
Yeah.
And it's not and then what is somebody going to look at them oh, how did they get it? You know what I mean?
Yeah.
So I think it's just that misconception or just that taboo of the lack of understanding around it.
I agree.
And I, I'm not going to delve deep into it, but on a surface level, I remember speaking with a patient, having that conversation of depression. And the denying the symptoms that they were telling me would have pointed to that, denying it to themselves, oh, that's not what this is, I can manage, I'm fine, and them expressing suicidal ideations and things like that, and then me having to just sit down and explain, hey, this is okay, this is you are going through something that you don't understand, and you're having these thoughts, it's not. You're not alone in this.
Yeah.
This is something that can happen. This is something that we would expect in a situation like this. And this is the reason why it's good to have a comprehensive care. And it's good to understand it from, the mental aspect, the physical aspect, and both of those, understanding it as a whole cohesive. But yeah, I think that's one of the biggest things where I've seen the resistance in our community of one wanting to get that help, and till their point that is detriment to them because they've gone untreated for so long, and then it starts attacking the rest of your body. But I think that's the biggest thing that I've seen the resistance with, and something that I am working towards, or to try to encourage myself and other people, is to, and even when I hear those conversations, to correct it right then and there, and say, hey, that's not what this is, and coming from it from an educational aspect rather than the misconceptions and the shame of it. And I'm there should be no shame. This, like I said, life leads you where life leads you, and that's okay. It's just, but be a little bit more compassionate, be a little bit more empathetic, and understand more than I think the biggest thing is the understanding. that gets you a long way.
all that stuff. How long you been in pharmacist? How long you been in the healthcare industry?
I started school in pharmacy school in 20. So after I got my 4-year bachelor's, I started, and it's another 4-year doctoral degree. Then graduated, the greatest year of 2020.
Okay.
So what a time that was.
Yeah,
but then I, after everything being shut down for a while and trying to get licensed to be able to practice, eventually I, got a job with Children's, but I was an intern there while I was in school, which allowed me to, practice what I'm learning, try to build those, essentially for my preceptors, try to build those skills that I needed to become a pharmacist, essentially.
Gotcha.
And I think we had such a phenomenal internship program, and it's just grown since then. So I was pretty much in it after my first year of pharmacy school.
So now 2 to 3 years, 4 years?
So as a pharmacist, it's been...
After you get your license.
Yeah, almost 5 years. Yeah, 4 years.
Okay.
Four and some change.
And
so this is my 5th year, essentially.
And you have seen some others that are in the pipipeline.
And
are you mentoring anybody?
When I came... And even when I was in pharmacy school, I was the only pharmacy student that was Somali.
Okay.
And then my 4th year, when I was in clinical, so I wasn't really in the school setting as much, but I was an ambassador, a student ambassador for incoming students. So I remember seeing some Somali students applying and talking to them, and then when I was a 4th year, I had seen them here and there, and they were oh, I remember you. And now I hear, because I do have intern that's Somali, and there's like
You say
5
Somali night?
interns that are Somali interns.
Okay, interns
Yeah.
that are Somali. Okay, I
sorry,
thought they made it like a Somali night that they come together and speak. Okay.
Yeah,
Okay.
no, but one even like hijabi in general, but just Somali students. There's so many of them now. There's at least like 5 that are
Nice.
4th years about to graduate.
No, nice.
Yeah,
Nice.
and one of them I'm actually a preceptor, and I'm hooding her
Okay.
for graduation on her hooding ceremony.
Okay.
when she becomes a doctor if she graduates.
Good,
so,
good, excellent,
So
excellent.
definitely a rewarding experience to see that, and that becoming, just seeing more representation for us.
Like that.
I love it.
I know. I think the young generation that are coming up, I think will make some fun, some excellent choices that will just only, enhance and thrive and make the community thrive. So, what advice do you have somebody who's in kind of sort of undecided whether that they wanted to pursue, the same avenue that you have?
I
in terms of
think definitely the first thing I would say is try to find a way, which a lot of hospitals I would say are a little bit more easier to have those resources, but try to get into some shadowing program.
Okay.
And we specifically have those opportunities, but
Nationwide.
At Nationwide. But I would definitely say try to get into a way to pursue shadowing.
Okay.
And just to see what it's like.
Okay.
Just to see even if it's an environment that you would, be able to see yourself in or could, learn from. I think that's the first step, because it is a challenging journey. It is, like any doctoral degree.
Yeah.
It's a very challenging, very fast-paced environment, journey at least.
Okay.
So before you make that commitment, I would definitely say get those shadowing experiences, and
Okay.
you can do it over a period of time, over some months, over either
See how
a
you
year.
like it.
Yeah, see how you like it. Get your feet wet,
Yeah.
and then going from there, just building that relationship. If you see somebody that in that experience that, hey, I would like to see if you have any mentorship programs,
Yeah.
or mentee mentorship
Right.
programs, and those are available as well. Just to build that connection once you get your feet wet, to have that one-on-one connection, and to be able to get that more realistic view of like, hey, this is what it really is, and this is what really is gonna take.
I'm thinking it might take 3 years, but it's really going to take 7 years.
And now they do have. When I did it was a 8-year
Okay.
degree, so including my bachelor's. But now they do have it where it's from college you have fast-paced program where you can essentially do it in 7 years.
Okay.
Only
a year.
or 6 years, depending on like where you go to.
Okay.
So hey, that your payments,
It
your
does,
tuition.
It does.
But no, so I think there's those avenues. But I would definitely say at least get your feet wet, then see how you like it,
Yeah.
or what questions you would even have, and then see if there's some mentorship program.
Okay.
See if there is an avenue for you to go into. And I actually am. And one of my best friends started a nonprofit organization. It's called Science Sisters.
Science Sisters?
Yes,
Excellent.
and it is essentially just a mentorship program.
Okay.
And we also, our main objective is to reduce those like barriers
Okay.
for minorities, geared especially towards like Black women, but in general, women and minorities in the STEM field. So we have grants and scholarships available.
Okay.
That we can give to patients not patients, sorry. I'm such in a workload.
Yeah.
to students.
I'm trying to get you to work.
Yeah, I'm such in a workload. But that we can provide to students to help with the financial barrier.
Okay.
Applications alone are so expensive. Even like getting the test materials, the prep materials, just even get into, whether it's medical school, pharmacy school, dental school, any of those things, it's very expensive. That's a big barrier, the financial barrier. So we do help with those to give them those resources and that's and then having a mentorship program where depending what field that you're in.
Is this for all healthcare or just pretty much any
all healthcare?
Okay, all healthcare.
Whether it be optometry, dentistry, medical, pharmacy, lab, research.
Okay.
Which I think is a big thing too. That
it is.
We don't have as much representation. But
in research.
Research is huge.
Yeah, it is.
It is. And especially because I don't think our people like us are not studied as much. we're not the standard, and that affects our level of care, and the treatments that we get. But yeah, so we have that mentorship program also where we can pair them with those people in those fields too. Yeah. But in general, I would say definitely shadowing, finding, reaching out. A lot of it is you have to be able to take that ownership of that and figuring out that
actively managing.
Active management essentially.
And now looking back, you spent 8 years in school. And now looking back, what are the the most challenging things that you can just say, man, that was a difficult time?
I think
exam week.
But exam week is like either every week or every 2 weeks for us.
Oh wow!
So it's
constant.
Very fast
paced.
Very fast paced.
Okay.
And I think definitely something that like I said, I've provided that I didn't have is that representation or that mentorship in that specific sense. Like I did have mentorship, but just in that sense of from our demographic. Yeah. And having somebody to be like, when you see yourself is somewhere.
Absolutely.
So it makes a huge difference of comfort,
yeah.
of just feeling like belonging,
Yeah, absolutely.
So I think that was one of the biggest challenges, just having to navigate that on feeling like I was navigating it on my own essentially, you know? And the course load, it was very fast paced. It's very fast paced. But I think one of the best things is being able to build those relationships in school and to have that community. And like I said, I see now where, the girls that I have mentioned that are, Somali, they have their own, network. They have their own group where having a community makes a huge difference. It makes a huge difference. So, but I would definitely say that those are some of the challenges.
Well, thank you so much for taking the time. This has just been an excellent conversation. And I think, we need to do more of these with people like young professionals like you that who are actually, hitting the ground running and hopefully can make an impact in the long term in our community.
I hope so. This was such a great conversation, and I look forward to, even expanding this, and hopefully we can see more of it.
All right. Sounds good. Thank you so much for your time.
Thank you so much.
Assalamu alaikum.